So our first speaker is Dr. Aysha PAP. She is the consultant cornea and refractive surgeon at Srikanth Eye Care Hospital, Calicut. She will be talking on corneal catastrophe, responding to chemical injuries.
Good afternoon, everyone. So I'll be mainly talking about the chemical injury, in that the acute or the emergency management of chemical injury. So we all know the chemical injury is one of the true ophthalmic emergency, which often results in ocular morbidity when it is not treated in a proper way. Alkali injuries are more common and can be more dangerous than acid injury. Coming to the epidemiology, 2/3 of the affected cases are mainly seen in the young males, especially in the age group of 20 to 40, and same way 2/3 of the affected cases are mainly seen in the workplace, especially in the industrial laboratory workers, construction workers, agricultural workers, sanitizing or cleaning crew members. Alkali acid attacks are more common than the acid injury. In India, common are firecrackers, lime, sometimes accidental injury with holy colors. Nowadays, it's also seen with this automatic battery acid burns, which mainly consist of a sulfuric acid, hydrogen, and oxygen. When we are charging, what happens? This explosive gaseous material comes out, which causes one of the important causes of chemical injury. Etiology, we all know, two type, alkali and acid. In ammonia, this is mainly seen in the fertilizers, refrigerants, cleaning agent, lye in the drain cleaners, lime, calcium hydroxide, mainly seen in the plaster, mortar, cement, whitewash. This is the most common cause in the workplace. Lime actually has a poor penetration when compared to the other alkali agent, but toxicity is increased by retained penetration time. Acid substances, sulfuric acid commonly seen in the car batteries and industrial cleaners, hydrochloric acid in the chemical laboratories, and the chromic acid, which is an intermediate in electroplating. Why I specifically mention acid and alkali like ammonia, sulfuric acid, car batteries? Because none of the patient come and say I had an acid attack or an alkali attack. Most of them come and say I had an exposure to the car batteries or a chemical laboratories. Based on that, we should classify into the acid or an alkali pattern. Coming to the pathophysiology, I'll briefly explain. When we have exposure to the acid, what happens? It damages and precipitate the protein. This causes the coagulation of the protein and barrier. Actually, this barrier doesn't allow the acid to penetrate inside the eye. While coming to the alkali, this is all a lipophilic substances. This causes the saponification of the cell membrane, causes lysis, causes the enzyme activity will be increased. Thus, the penetration of alkali will be more when compared to the acid. That is why alkali attacks are more dangerous than the acid attack. It actually goes inside the eye, affect the lens, anterior chamber, trabecular meshwork, and causes more complication. So what is the immediate management? A patient is coming with chemical injury. The first step is take the patient to the emergency OPD. The initial thing is the thorough wash. In the wash, which solution we have to take? How we should do the wash? How long we should do the wash? Always the solution should be more compared to the osmolality should be more compared to the cornea. Avoid using tap water because this is a hypotonic solution. So whenever you use the tap water, the chances of corneal edema will be more. It can be either 0.9% normal saline, ringer lactate, balanced salt solution, buffered borate. In that buffered borate, the ideal one, we call it like a polyvalent amphoteric solution. Why? Because it binds to the both alkali and acid in an equal way and it doesn't cause any exothermic reaction. So ideal choice should be always a diphoterine, balanced salt solution, then comes the ringer lactate, then comes the normal saline. But which is available in emergency OPD? If it is a normal saline, we should start with normal saline. Don't wait for the BSS or RL. So I'll show one video of the demonstration of the wash. So ideally, when a patient comes in the emergency OPD, the set should be ready. You should have a kidney tray, and the most important thing is the pH strip. Sterile buds, speculum, and the important one is the solution. So when a patient comes, counsel the patient that we no need to worry. Put a drop of paracaine, check the pH, always note the pH and start irrigating from nasal to the temporal side. Ask the patient to look down and up and start irrigating. Keep irrigating for 10 to 12 minutes. Check the pH. If pH is not balanced, always important step is invert the eyelid, check for any debris matter. Minimum 15 to 30 minutes of irrigation should be done. You can use about 1 to 3 liter and always check the pH 15 to 20 minutes. Whenever the pH is neutralized up to 7 to 7.2, you can stop the saline wash. Next comes the history and assessment. Always take a detailed history. Ask the patient what was the solution, what was the concentration of the solution, how was the impact force, what was the volume of the solution. Then comes the slit lamp examination. If it is white cornea, you have to be worried, that is total limbal ischemia will be there. If it is congested also, you have to look for the limbal cell. Always examine the other eye also. Do a fluorescein staining and check for the any epithelial defect. If it is a child, always do the examination under anesthesia. Then comes the classification of the chemical injury. We have a 4 types. Based on the slit lamp examination, we are classified into Hughes classification, modified Hughes-Roper-Haar classification, Duas classification, and McKinley's classification. So what is the importance of the classification here? Why are we doing classification? The main importance is to know the prognosis and the outcome, to know whether it is a acute wise or a chronic reaction, chronic attack. Always stick on to the one classification. Don't stick on to 2 or 3 classification. The best one is the Duas classification, because here we are taking only 2 clinical findings. One is the limbal involvement and 2 is the conjunctival involvement. Grade 1 and 2 always has a very good prognosis, because the limbal involvement will be up to 3 years and the conjunctival involvement will be less than 30. Where 3, 4, 5 has a 4 and 5 has a good to guarded prognosis, and the 6 has a very poor prognosis. Based on the classification itself, we can explain to the patient what are the chances of complication might occur in the early reparative or a late reparative phase. This is the picture where in the A, you can see there is only epithelial defect, that is grade 0 and 0. There is no any limbal or a conjunctival involvement. Whereas in the B, it is a 7/60. There are 7 clock hours of the limbal involvement is there, and 60 clock hours of the conjunctival involvement. And the grade C, there is a total limbal involvement and the 80% of the conjunctival involvement. So what are the aim of a treatment? The main aim should be to promote epithelialization, to prevent corneal melt, control IOP and inflammation, and to prevent cicatrization. So in the acute phase treatment, the most important step is the promote epithelialization. The best one is, the first thing is artificial teardrops. Use preservative teardrop. It helps to reduce the persistent epitheliopathy, reduces the recurrent corneal erosion, and always it accelerates the visual rehabilitation. Bandage contact lens also say do the same thing. It helps in basement membrane regeneration and enhances epithelial stromal adhesion. Cycloplegic we can use. It reduces the pain. And AGM, whenever there is any increase in IOP, you have to consider Timolet. If it is not controlling with drops, you have to think about the oral and AGM also. Prophylactic antibiotics to reduce the infection, and steroid. Here's comes the role of steroid. You can immediately, when the patient comes in the first 7 days, you can start the steroid 1% prednisolone acetate based on your, and the dosage should be based on your grading of the injury. What are the drugs that supports and repairs minimal ulceration? Here comes the role of vitamin C. So what does this chemical injury do? It mainly damages the ciliary epithelium. Thus, the less collagen is produced. It decreases the aqueous humor, ascorbate aqueous humor, decreases fibroblast collagen synthesis and inflammation. So we can use 10% topical ascorbate or oral vitamin C, oral tetracycline, and collagenase inhibitor. When coming to the early reparative phase, this is the phase that comes after 1 week. Here the complications are mainly chances to come. So if epithelium is not intact, epithelium is not healed, you have to immediately stop the steroid. This is the phase where the corneal ulceration starts, and continue other medicines. In the late reparative phase, this is the phase, if it is grade 1 and 2, everything will be healed. But grade 3 and 4, complication cause like ectropion, entropion, symblepharon, corneal scarring. This phase you have to think about conjunctival or tenones advancement, amniotic membrane transplantation, therapeutic penetrating keratoplasty, and tissue adhesive. In the rehabilitative phase, inflammation, everything is reduced. So our main aim should be to give the vision to the patient. If there is a severe corneal scarring, we can do limbal cell transplantation, PK, and keratoprosthesis. To conclude, I would say we need a thorough and immediate evaluation and intensive treatment. Always understand the pathology. Explain to the patient if it is acid and alkali. If it is grade 5 and 6, explain what are the chances of the complication to the cup. So our goal should be to restoration of the normal ocular surface anatomy and lid position, control of the glaucoma, and restoration of the corneal clarity. Thank you.
Thank you, Dr. Aysha, for that detailed